Welcome to our national webinar in recognition of Mental Health Awareness Month, Leading Together Public Health and Mental Health Partners Collaborating to Address Health Disparities. This national webinar is presented by ASTHO's Tobacco Control Program. We have organized an enriching discussion today in partnership with the National African American Tobacco Prevention Network and the National Behavioral Network. My name is Alicia Smith, and I am the Director of Chronic Disease Prevention at ASTHO. I'm joined today by ASTHO's Chronic Disease full team and also by our Chief Medical Officer, Dr. Marcus Plesha. Before we begin, I want to quickly provide everyone with a brief overview of today's webinar. We are going to begin with background remarks from Dr. Marcus Plesha before hearing from state and community partners on their presentations by a number of stakeholders that will be representing the state of Pennsylvania. We will have ample opportunity for audience participation, so we highly encourage you all to chime in with your questions in the chat box throughout today's presentations. And finally, we will end the webinar by having all of our national partners on the line share some more information about their tobacco control resources and opportunities to contribute to some of your work who's listening in today. As a housekeeping reminder, please plan to listen to today's webinar through your computer speakers or over the phone, but please do not use both methods. Sometimes that causes feedback for us. Everyone's phone line will be muted for the duration of the webinar, but you will be able to submit questions for the presenters at any time all throughout today's webinar on the screen chat box. Slides and the recording from this webinar will be available to all registrants via email, and we will also be the final link will also be shared on ASTHO's website in approximately 2 weeks. So let me check to see if my colleague, Dr. Marcus Plesha, is on.
Yes, I'm on the line.
Wonderful. Well, I will turn things over to you to get us started for the discussion today.
Great. Well, thank you, everybody, for joining our teleconference today. I am Marcus Plesha. I'm the Chief Medical Officer for ASTHO. And in that role as Chief Medical Officer, I have to say this is a particularly compelling topic for me, so I'm really looking forward to hearing from the speakers and hearing some of the discussion. Let me start off by just giving you a little bit of background about us. I think Alicia may have done some of this, but we are the Association of State and Territorial Health Officials. For those of you who don't know, we go by the acronym ASTHO, and we're a national nonprofit organization. We represent the leadership of public health agencies in the United States, in the states, in the territories, in the freely associated states, and in the District of Columbia. And so in doing that, we basically represent more than 100,000 public health professionals that are in these 59 agencies that are part of our membership. ASTHO has three primary functions. We serve as an advocate and a voice for state and territorial public health agencies. We develop public health leadership at the executive level, and we provide capacity building and technical assistance to state and territorial health agencies. Today's webinar is probably fits all three of those functions, but particularly I think helps with some of the capacity building and technical assistance we work on. And the webinar is intended to highlight some examples of state and territory public health agencies that have connected with community mental health providers in order to address specific mental health disparities. In this case, we're going to specifically focus on some of that work that's occurred through tobacco prevention efforts. This webinar will describe the burden of mental health across the country, and then we'll present a case study on how implementing comprehensive tobacco prevention strategies in African American communities can be helpful to tackle some of the mental health disparities that are seen there. There's three main purposes we hope to accomplish with this session using our interdisciplinary panel of experts. We hope to look at ways that states and territories can coordinate better with mental health agencies and describe some of the functions and steps that have been used to address this around some of the coordination between tobacco control and mental health. We want to spend some time talking about the specific needs of disparate populations and highlight how a coordinated approach, like you'll hear about from some of the speakers today, can really help support these populations and help meet some of the needs in a culturally appropriate way. And then finally, we hope that we'll be able to share and disseminate resources and ways to demonstrate the value of implementing this work in a coordinated and culturally appropriate way. This webinar is an opportunity for a group of impressive panelists from different disciplines to provide some of their insights on these issues to you, and we'll be introducing them shortly. We hope you'll benefit from today's discussion, and as Alicia said earlier, we invite you to please submit questions through the chat box throughout today's webinar so that we can have a good, lively discussion at the end. So now I'll turn it back over to Alicia to get started with our speakers. Thank you.
Certainly. Thank you, Dr. Plesha. It's my pleasure to introduce Judy from Pennsylvania Department of Health. She is the director there of Pennsylvania's Division of Tobacco Prevention and Control. She has been a leader in tobacco control and disease prevention for nearly 2 decades. So we have lots to learn from her today. We are very excited. Thank you so much, Judy, for joining us this afternoon. I will now turn it over to you.
Thank you very much. So first, thanks to ASTHO and all the partners for inviting Pennsylvania to be part of this important webinar. I'm leaving this first slide up because we have our 3 logos of the wonderful agencies that are in a very strong partnership here in Pennsylvania. However, we wouldn't be here if there weren't 4 other logos that should be joining us, and they would be CDC's National Behavioral Health Network for Tobacco and Cancer Control, the Smoking Cessation Leadership Center at the University of California, San Francisco, and of course, Substance Abuse and Mental Health Services Administration. In Pennsylvania, we recognize that our landscape continues to change and that we need to stay focused on the importance of maintaining existing partnerships and collaborations and identifying new opportunities through partnerships and collaborations at the federal, state, regional, and local community-based levels to improve our fiscal efficiencies and expand our program service delivery. We hope that sharing our approach to addressing the health disparity of tobacco use in adults across our diverse populations with behavioral health disorders will engage and empower you as we move forward together across our nation. So without the data, we can't even begin our conversation. This data is specific for our webinar today. And as you will see, in Pennsylvania, 37% of adults reporting poor mental health are current smokers. In the United States, we know that the current smoking among adults with behavioral health conditions is approximately 35%, nearly twice the rate of those without a behavioral health condition. You'll also see, unfortunately, that right now, only 43% of mental health treatment facilities in Pennsylvania and 58% of substance use treatment facilities use even the Ask, Advise, Refer brief intervention to screen and refer patients to services. So there is relatively little support at the moment to address tobacco dependence within the behavioral health system. So what we'd like to share with you today is how we launched our main efforts to address this huge disparity. And it starts with a wonderful summit that we held November 16th and 17th of 2017. Again, this was through our partners NBHN, SCLC, and SAMHSA, who provided an extraordinary amount of technical assistance to us. And we were able to partner and actually submit our application for the technical assistance through our Department of Human Services Office of Mental Health and Substance Abuse Services. And through that process, we were able to really bring together key decision makers. And at our summit They included all the leaders and stakeholders in behavioral health and community health, insurance providers, cessation and addiction specialists, and our pharmacy experts. So the day and a half format began, and you will see that it was very precise and concise. It guided us so succinctly that in this day and a half, we were able to bring together our partners and have them do what is called a gallery walk, which included posters on national and state data, current policies, quality of care, and then we were able, through an extraordinary facilitator, to actually establish some of our baseline data points to measure our progress, identify specific strategies to overcome the existing barriers, and actually create action steps. So during the session, the attendees worked to develop Pennsylvania's action plan, and they focused on, as you can see, increasing tobacco cessation activities, promoting tobacco use prevention, and reducing tobacco use among behavioral health population. Our session participants created working group leaders along with the Department of Health, the Department of Human Services, and the Department of Human Services Division of OMSAS. And since that meeting, we convened monthly meetings with our working group leaders. And during those monthly calls, we review our action plans and how we're progressing. We share our resources, and we continue to try to include additional partners and thank you, and look at what we can do. So one of the things on this slide is one of the actions that we took was our Pennsylvania Department of Human Services actually issued a bulletin to clarify Medicaid and Medicare reimbursement for tobacco cessation services. So as we move forward now, I had told Josh that some of my slides get very text heavy, and this is what we're entering into now. And so our intent is to provide you with key information. And as we move forward, I would invite you to, if you are able, take your focus off reading the slide, perhaps take some notes, and as we share more of our process and some of the unanticipated outcomes we have experienced, we hope that that will engage you even more in addressing this issue. So for the social determinants of health working group, they actually had several objectives: to assess community partners, to identify tobacco cessation partnerships, include the community partners and leaders and decision makers, such as the LGBT resource centers, public housing, homeless shelters, HIV centers, train tobacco cessation groups about behavioral health to treat the entire person, and explore opportunities to expand collaboration between the VA and the managed care organizations. So on the slide, we're sharing the actual accomplishments, which I would have to admit are totally astounding. We have surpassed several of our deadline dates and have really taken a quantum leap moving forward. In the payer group, they had only one objective, and the objective was to increase the MCO providers who can bill for cessation services. This was actually one of our largest groups, and while the original action plan had that just one objective, it included really the key decision makers that were representing both our physical health and behavioral health MCOs, which assured that addressing tobacco use is integrated into care initiatives. The efforts to add cessation education for community health workers have also been initiated. A common theme throughout our working groups has been recognizing the importance of actively working with other working groups. This group is actually working with our training, communications, and quitline working groups. Another working group is communications. Early on, they recognized the importance of adding additional group members and integrating their resources with all the other working groups. Provider education and training work group has been on the move and has done an extraordinary job in engaging with our Pennsylvania Pharmacists Association. We have very rural counties, and we recognized for a long time the importance of engaging with pharmacists to actually provide cessation counseling. And so we have successfully completed a training certification program that is recognized by Medicaid, so they are going to be able to bill for that counseling. And we've been able to work on making sure that everyone has a comprehensive listing of all the types of training opportunities available in Pennsylvania. The other interesting part about this group is there is an individual who has brought to us exploring how trauma-informed care could impact smoking cessation. And she has really been on the move. She's a skilled cessation provider. She's been, long-standing passion has been to integrate trauma-informed care. If anyone is interested, you can feel free to contact us. She's been working at the local level, but she's also presenting at some of the addictions conferences, one in Texas. I can't say enough about our Pennsylvania Free Quit Line. One of the best things has been with this work group that our actual vendor, National Jewish Health in Colorado, our operations quitline vendor, is actually an active participant in this working group. We have been working with our quitline vendor and are completing a pilot. We have for a long time collected on our quitline information and asking behavioral health questions. And so we have now are on the way of completing a study. We already know most of the outcome, to make sure we understand the needs of this population as they make their quit attempts to stop their addiction to nicotine. To that end, we already know that it will require longer periods of counseling as well as longer periods of providing nicotine replacement therapy and or the pharmacotherapies. So the strength of this group, again, is that it is ongoing and that we are meeting our targets of being able to implement these protocols as we are now engaged with the MCOs. You'll see on this slide that we actually presented a meeting, Health Homes for Pregnant Women with Substance Use Disorders. We have a very active protocol on the quit line that includes a dedicated coach, up to 10 calls, 5 during pregnancy, 5 postpartum with incentives. The other working groups include, of course, for DDAP, our substance use disorder, and our state hospitals. And the wonderful story here is that our state hospitals were two of them, we have 6. 2 of them were the very last individuals we were able to register for the state summit. And they came so excited because they wanted to be able to have their hospital go smoke-free. And believe it or not, they've surpassed their goal. Their original goal was to have one in place by 2019. They're ahead of that, and they had to deal with 5 unions and were successful in convincing those unions to partner with them. So the first one will happen in July of 2018, and they've already recruited a 3rd hospital to join us. Lastly, moving forward, we plan to continue to work with our group leaders. We are definitely expanding our partnerships with the managed care organizations, both of our regional primary contractors that provide a comprehensive tobacco control program in all 67 counties. are now engaging and creating partnerships along with our staff and our division. We are also planning to hold a one-day summit, hopefully toward the end of this calendar year, to bring together the partners who attended our strategy session and and take another look at where we've been. We do robust evaluation, and we'd like to be able to continue our plans and reach consensus on our next steps. Lastly, I think it's important for all of us to recognize something very important as we move forward together. This is a quote from Dr. Antoine Dooley, who is a professor of psychiatry and medicine at University of Pittsburgh, and he was able to get Western Psych to go tobacco-free in 2007. And this quote goes back to that time, but it hasn't changed, and it's a perfect fit for where we are now. This is a cultural change, and cultures change slowly. But if we continue to work together and don't give up, cultures do change. There is hope. Thank you.
Thank you so much, Judy, for that engaging and wonderful presentation. I'm now going to turn the floor over to Reverend Jesse Brown. Reverend Brown is the founder and executive director of the National Association of African American for Positive Imagery, which is a national nonprofit organization that's based in Philadelphia. NAATPI has its mission to mobilize the African American communities throughout the United States in the promotion of positive self-determination and good health. Thank you so much, Reverend Brown, for being with us this afternoon. The floor is yours. Reverend Brown, are you with us? You might still be on mute.
I was still on mute. Very good.
Well, awesome. Thank you for being with us. The floor is yours.
Thank you. When I was invited to be a part of this presentation, Josh says, please send me your slides. And I said, I can't do that just yet because we haven't had the death of tobacco yet. So I can't send you pictures of the party. And then he turned around and said, oh, I mean just a headshot. So there's your headshot there for me, of me today. And I'm going to kind of bring you up to speed on a current project that we're doing right here in Philadelphia around dealing with flavored tobacco and menthol. For about a year now, I've been going around with our health commissioner here in Philadelphia, and we've been doing radio shows, and we've been talking to the community. We've been raising the concern about flavored cigarettes and menthol in particular, and its impact and effect on communities and life. And with that, we had started putting together a little group of folks and organizations who were committed to seeing that happen. As you know, whenever these things come up, it is not merely our wish for the purposes of public health, but there's always a political component that goes along with this. And this is, of course, no accident at all that that would happen. In our process of doing this, the health department pretty much led the way in putting together the local coalition and identifying the groups and people that were going to be involved. One of the things I had said to the commissioner as we were moving through this is that we needed to have more community people involved, not just leaders, but the communities themselves, groups and organizations that represent the community in various ways for the issue around flavored tobacco and cigarettes and menthol was something that even the garden club could get excited about because they don't want to see butts thrown into their flower gardens. So this is an important issue to the community, and that we needed to take it to the community much stronger. In that year's time, the coalition pretty much stayed the same with the amount of people that it had. And finally, the commissioner wanted to introduce a bill to City Council around the removal of flavored cigarettes and stop providing access to them to our young people. About 4 weeks ago, the commissioner came and said, I wanted to have a talk with you. says we're getting ready to get one of the city council people to introduce the legislation, but I think that we're going to have to introduce the legislation without menthol. And I told the commissioner that was highly unacceptable, and in fact actually makes no sense, since the product that would have the greatest impact with young people would be a mentholated product in the first place, and it is menthol that has being used to increase initiation rates and makes it more palatable for young people to become involved. And I said that, I will pull together our own coalition of community folks who would want to see a much more comprehensive bill proposed to City Council that would include all flavored cigarettes, menthol, hookah, and e-cigarettes. I said that it also makes no sense to me that we would only target cigarillos and cigars for this legislation when all of the nicotine delivery devices are being used and menthol is being used to pave the way for their use. So you have now caught us 2 days away from when this legislation is going to be introduced into City Council. I have developed a local coalition around here in Philadelphia that is not necessarily here to oppose just the flavorings, but to say a comprehensive bill is what's necessary. And we have already gone around, and Monday we talked to literally all the City Council persons here in Philadelphia. We met with a number of City Council members themselves, and we tried to kind of get an idea just off the top of our heads whether or not a particular council person would have support for what we are talking about. Either way, the battle is always on when it comes to menthol. Too many communities are willing to allow, since menthol particularly affects African American youth, they are much more likely to want to drop that off of their bill versus carry on and deal with the fight that comes ahead of us. And we have taken on that responsibility, and our local coalition has taken on that responsibility to make sure that as this bill begins to get moved, that number one, we get a good bill on the table that will deal with all of the nicotine delivery devices, and of course, make sure that all young people are under the protection of this kind of a bill in the process. And we've had to come up with some new language for them around these things and what it means. Particularly for the African American community, some of this look at this as the new Jim Crow laws that are put on the books that disproportionately affect one part of the community versus another part of the community. In this case, we know that white youth are much more likely to be lured by flavored tobacco, while African American youth are much more likely to be lured by mentholated tobacco products. And if you did not cover that in the legislation, then obviously you are putting a disproportionate burden on one community or another in the process. So we have been raising these issues both privately, and very soon we will be raising them publicly as we prepare for our press event and the events that will come after this. But one of the key things that's very important in this is that you build a community support base supported by, the voluntaries like the American Cancer Society and the Lung Association and the Heart Association and the other groups that work along with us. And that takes a little bit more work than just going in and saying, we want you to support this. It usually means taking some time to develop a relationship with them. And that means you going to their meetings and they maybe coming to your meetings and finding where the synergy is that they can support your particular position, and particularly be an advocate for strong public health and strong mental health around these issues. And some people, of course, know some things, but it takes a little education and it takes a little time. And that's what we're spending time doing right now, is building that coalition. And even though we're going to have a press event in a couple of weeks, we don't look at that as the end, but a beginning and a continuation. there are young people that we can tap. Here in Philadelphia, we happen to be fortunate that there are some young people that are already part of a tobacco-free organization sponsored by Tobacco-Free Kids. And those kids are just magnificent. I have been with them on the radio. I've been with them in community meetings and in community organizations. Not only are they articulate about the issue itself, but they know how to say it in a way that relates to their own peer group as well as adults. And that's very important, is to make sure that all groups in our community are touched and understand with some depth of clarity what's going on around them. And these kids do a magnificent job. So I'm hoping to continue to work with them, as I have already done that in the past, and that we will continue to move forward in our community coalition building and keep honing our message to the public. And we're trying to make sure, this is one of the things that I had always liked to do in these matters, is we want to get our message out there first so that anybody else has to respond to what we're putting on the table, to our narrative, to our story. Let them respond to that rather than waiting until somebody else tells it their way and then we have to respond to them. So it's all part of getting into the game early to deal with the addictive behaviors and the addiction that tobacco can cause in our neighborhood and communities. And let me leave you with this note that I have also found out in this. One of the things that we used to do in NAPI very early on at the NAATPI, we kind of call our organization in its early days NAPI, but one of the things we would do would be to suggest to people that they ought to quit smoking. And we had our little quit kit. And it started out being an apple and some mint candy that of course had menthol in it, and a few other things like that. And then we had a couple of books, the Pathways of Freedom book, and I think another one's called Breathe Free that we created along the way to help people begin to kick the addiction. And we found out that the addiction in some cases was part of a process of multiple addictions that some individuals had. And we even found groups like the Narcotics Anonymous group. They were, of course, dealing with illegal drugs and maybe even alcohol, but they then turned around and suggested to their friends that they should smoke. And we kept asking the question, why are we saying one addiction is somehow all right over another? Shouldn't we be helping people deal with all of their addictions and their addictive behaviors in the process? And in doing that, we didn't beat them over the head over it. We simply pointed out that if we are trying to help people find a healthy lifestyle, then tobacco is no better an addiction than the drugs or the alcohol that they might have been addicted to or participated in the first place. And we should all look at that. We also found in a number of other instances some more unique things that went on. For instance, in group homes, both teenage group homes as well as adult group homes, one of the processes in a group home to get people to do the right thing, they were allowed or disallowed to smoke. It was part of their reward system in group homes, and sometimes in mental institutions and in mental wards in some hospitals. One of the few places that they still allow people to smoke. And we found that to be fascinating as well, and attempted to work with our colleagues in all of those areas to suggest other ways in which we could help their folks that they were dealing with deal with the addictions that they had. Maybe we ought to look more closely at all addictive behaviors and not just the ones that at the moment cause you the problem or cause you to be in jail or cause you to be in the mental institution or whatever the situation was, but that you look at it from a broader perspective that, you know, addictive personalities, addictive behaviors is something that we have to get over, and substituting one addiction for another might not lead you to the healthy lifestyle that you were looking for. So we have worked with a number of agencies and groups to help identify ways in which we can better deal with that. And that included the tobacco issues as well as, and particularly menthol in that game. So I've approached this from a number of different areas. Our agency has approached this from a number of different areas. We have worked with, as you can see, across the board with a number of groups and organizations. Although my primary focus may be around tobacco and menthol, it doesn't, we fully recognize that that also has to be integrated in other ways, and particularly in the mental health world, and making sure that these things are dealt with there. We might be able to fix one problem, and we might be able to get them out of the mental hospital, but at the same time, we send them out addicted to tobacco in the communities and our neighborhoods. So with that, I'm hoping very soon that we will have a party, and I'll be able to show you the party pictures where we have put tobacco to death and buried it. But until we get there, we will continue to create advocacy organizations and tackle these issues one issue at a time, and trying to bring greater health to our communities and trying to get other people to see how important it is to live a healthy lifestyle in their communities or neighborhood. So I think that's it for the moment. I don't need to prolong this any longer than necessary, and there will be time, I believe, for questions that people will be able to ask, and I would be more than happy to respond to those at that time.
Great. Thank you, Reverend Brown. And I sure hope that I'm included in that invitation list for the party, because that certainly sounds like a party that I'd like to go to. So thank you for your presentation. And yes, we are taking questions via the chat box. So folks, if you have questions for our speakers today, please don't be shy and drop those in there, and we'll get those going for our Q&A session. Before that, I would like to now turn it over to Dr. Lauren Robinson. Dr. Robinson is the Deputy Secretary for Health Promotion and Disease Prevention at the Pennsylvania Department of Health. Her focus is on preventive health and wellness programs geared toward improving the well-being of all Pennsylvanians. Thank you so much, Dr. Robinson, for being with us today. The floor is now yours.
Thank you, Alicia, and thank you, Judy and Reverend Brown, for your presentations. And so I spoke a little bit about this last week here in Harrisburg, but this is an issue that is deeply personal to me, and I wanted to start out my presentation or my reflections with just a personal story. So growing up, my sister and I grew up in a very healthy household, always expected to participate in some type of physical activity, whether or not we were good at it or not. We were lucky enough to grow up in a smoke-free home, and our extended family in general also had smoke-free homes. My sister was diagnosed with severe mental illness when she was 23 years old, and subsequent to that has developed tobacco use disorder. And in the 13 years that she has kind of struggled with mental illness, she's been hospitalized in 3 different states. She has been arrested. She's had a real challenging experience. And in the course of that, in the course of her tobacco use disorder, no one has ever spoken to her about smoking cessation or about tobacco cessation. And that, to me, it's just such a personal highlight of what is definitely a systemic issue, and definitely speaks to what Reverend Brown just spoke to, where when a patient is in a hospital or someone is working through transitional housing, they start using tobacco and somehow see that as their solace, and there's no kind of conversation about the fact that there's such danger and such diminution of their lives that is associated with developing a tobacco use disorder and not having the support or the counseling to kind of get healthy from tobacco while seeking mental health and mental wellness. So this work is so very personally important to me, and I thank each of you for your work on it. When we think about lessons learned from Pennsylvania, we've got a lot of people in Pennsylvania working really hard to overcome and manage behavioral and mental health issues, whether it's a patient, an advocate, a health system. It's unique in that for us, we don't think of it as political because it's a shared goal, right? We all want to have mental and physical health. And just like many of you, we see challenges across our diverse populations, and specifically in our underserved populations and our populations who have mental illness and struggle trying to get to that point where they consider themselves mentally well, and also have a supportive kind of mental health team. Tobacco use disorder is something that so many people struggle with, and it creates a challenge that contributes to health disparities in Pennsylvania and beyond across our country and really our world. I think our national partners at SAMHSA continue to report, quote, that communities of color tend to experience a greater burden of mental and substance use disorders, often due to poor access to care, inappropriate care, and higher social, environmental, and economic risk factors, end quote. And I think this is, again, speaking to what Reverend Brown was talking about when we talk about policies that are put in place that can disproportionately affect communities of color, as well as underserved and under-resourced communities. And so when I think about what have we done or what works or what are the potentials for synergies here, the important part is that we think about health equity, right? So making sure that everyone has access to quality health care and health-promoting lifestyles. Sometimes this means that you have a great advocate in the government, like we have in Judy Oakes, who has taught me so much since my arrival to the department 3 years ago. And sometimes it means you've got boots on the ground. So the work that Reverend Brown has done and really working with the communities to let them know about the dangers of smoking and how even if you are someone who smokes or even if you have this history or no matter where you come from, you are the best advocate and you are the one who can really bring the words to the people and make their stories count. So we continue to fight for health equity here in Pennsylvania. I think the biggest lesson that I take away is to look beyond ourselves and look beyond each of our own sectors or each of our own expertise, to look to collaborate with those who work directly with these most vulnerable populations and most vulnerable communities. You know, when I think of our government partners, I think of our partners at the Department of Human Services or the Departments of Drug and Alcohol Programs. But as a deputy and in a leadership role, I have the opportunity to work with people who are in the Department of Revenue or the Department of Energy. And every time I walk into those circles, thinking outside the box about how can someone like this impact the lives of someone who has a mental illness and is struggling with tobacco use disorder. You know, when I think back to what Judy had said on her slide about social determinants of health, I'm trained as a doctor, and I know that as a doctor in the hospital, I can write for a nicotine patch and I can counsel patients to stop smoking, and I think that it's kind of only my job and I'm doing that piece. But when you look at the work that Judy has done to empower pharmacists to talk with patients about tobacco cessation, when we take that a step further, who are other people in the community that we can partner with to talk about tobacco cessation? Because really, every single one of us can be a tobacco cessation expert. It doesn't take a particular degree or for someone to be behind a counter or wearing a white coat to really be a leader in that space. So, you know, as a leader in the Pennsylvania Department of Health, I continue to see this use of collaborative practices at the baseline and really the groundbreaking and really the whole foundation for the successful initiatives that actually work in communities. It's when we work beyond what we see and work beyond who we are that really target the social determinants of our health and can really uplift our most vulnerable communities. Something that we touched on just a little bit, but I think is something that we'll continue to hear about and really need to unify around is around vaping or e-cigarettes. I was in rural Pennsylvania last week on Thursday speaking with a group of middle schoolers about vaping and about e-cigarettes. And it's interesting because when we first thought about doing this event, we thought about going to a high school because everyone always thinks about high schoolers and smoking, and the high school was not available that day. And so we decided to partner with a middle school, and the middle school principal initially was like, well, I don't know that this is going to be that relevant because I don't think these middle schoolers are smoking. But if you look at what the data says, we know that that's just not true. And so I think if we know that, you know, at least in Pennsylvania, 13% of Pennsylvanians altogether are everyday smokers. We still have 13% of adolescents in Pennsylvania who are smoking cigarettes, and about 24% who are using electronic vapor product or an ENDS or a vape or a Juuls. And so we really need to think about in our vulnerable communities especially how we address that. So I'll close by saying that we have to stay vigilant in our work to address the behavioral and mental health issues, remembering that we can fight these battles every day as individuals, but we're stronger when we fight as a community and as a unified team. And we know that every community, regardless of where it's situated, regardless of who it's made up of, where they come from or what they do, every single community is worth this fight. And I really thank all of you all for participating today, and I look forward for your questions.
Terrific. Thank you so much, Dr. Robinson, for joining us and providing those summary remarks, and thanks again to Judy Oakes and Reverend Jesse Brown for joining us as well. This is Josh Berry on the ASTHO team, and I'm excited to participate and moderate the question and answer portion of our webinar this afternoon alongside my colleague at ASTHO, Ramya Dronam Raju. So as a reminder, everyone, please plan to use the chat box to send in questions to the speakers who have joined us this afternoon. Phone lines are muted, and we'll be happy to take the next several minutes to put your questions to the speakers that we have joining us. I'll also take this opportunity to remind everybody that the webinar is being recorded, and so a full recording and slides from our webinar will be sent to everybody via email later this week and will also be available on the ASTHO website. So in turning to the questions that we're starting to get through the chat box, the first question we have, I would like to turn to Judy in Pennsylvania and perhaps to Dr. Robinson as well, if you have anything to add. Judy, you made mention of involvement of the Pennsylvania State Tobacco Quit Line in describing some of the next steps from your state strategy session in Pennsylvania. And every state has a quit line and an opportunity to deliver smoking cessation messaging and nicotine replacement therapy to folks with mental health disorders and other folks who need those resources the most to quit smoking. So Judy, could you go into a little more detail about how you've been working with the Pennsylvania State Quit Line since the state strategy session and what you've seen come about from that effort thus far?
Sure. I think that because our vendor had attended the state strategy session, even though we had earlier on recognized that we were able to really drill deep into the data that we were collecting from our quit line, we were able to identify where people are living because we work with multi-unit housing. We're able to expand many of our efforts. We've always asked the LGBT, and in addition, some mental health screening questions. And so one of the best things that happened for us is once that the representative from the quit line came, she was able to hear firsthand from Pennsylvania leadership their vision and what they felt they would need from a quit line. So in addition to doing the research, I think there are 4 of participating states, and it's an 18-month study. We already know that it's going to require a great deal more in the way of resources for individuals diagnosed with behavioral health or substance use disorder. And to that end, we're now working with the managed care organizations, both the physical health and mental health. They had to submit a plan as to how they were going to integrate addressing tobacco use. And so we have expanded our dialogue with them through our quitline vendor as well, recognizing that there's going to have to be a continuum of care. And so one of the things that we do best, and we're fortunate to do, are pilots. And in a pilot, we always work with our statewide external evaluator and make sure we have an evaluation plan in place ahead of whatever we're piloting, that we then look at it during the pilot and then, of course, at the outcome. And so some of the managed care organizations are exploring the possibility of having trained cessation specialists as part of their network, and they will provide cessation services and then utilize the quit line. So some may be piloting we have a e-referral system with our quit line with a feedback loop, so that if an MCO network organization refers to the quit line, they will get feedback information if the patient enrolled, if they didn't enroll, and so every encounter they have, they'll know the status of the patient. Sorry, I'm going very long. I hope that gives you just a little blink of how well this is working. So if anyone has any questions, they can certainly use my contact information.
Terrific. Thank you, Judy, for elaborating. I wanted to give Dr. Robinson the opportunity to see if she has anything to add from her perspective in the Pennsylvania Health Department.
No, I mean, I think Judy really covers it well. I think it's very easy on the external side of any of these pieces to say kind of what everybody should be doing, but I think really trying to put pieces that hold people accountable for the measures that they're measuring is important, and making sure, on our end we're all about education, and we can do a ton of education and health promotion from a health perspective, but if the MCOs aren't making sure that providers are being paid for something, then that education is not going to happen on the behalf of providers. So we've got to make sure that we give our partners the tools that they need to be successful, so that we can make sure that all the communities that we serve are successful. And sometimes that may look different in different states, and it may look different for different stakeholders. But I think that the important part is to hear what the pain points are from our partners and figure out how we can partner to address those and move them forward.
Thank you, Dr. Robinson. We have another question in the chat box for Reverend Brown. Can you address working on the tobacco issue within the faith-based organizations? In our work, we have found that there's a stigma about admitting that someone smokes. How do you address that stigma? And thank you for your work.
Oh, excellent question, and you are right. In some denominations, they tend to be that lean more toward fundamentalism. There is both a stigma and it can even become a social outcast in those particular things. One is we tend to take the tobacco addiction away from being a smear on one's soul, if you will, and we talk about it from a health standpoint, in which case all of us have some health issues that we need to deal with, some bigger or more than others. And we have developed church-based programs. Sometimes it's dealing with weight and other issues, or high blood pressure, or cancer prevention, or prostate cancer. And within the context of talking about health, that tobacco becomes one of those issues that they may need to deal with. And we tend to work with some of the denominations, they have what they call church nurses. Some of these are actually professional nurses, but they are a community group that provides assistance in their church in particular and with their neighbors. And we sometimes go through them to help deal with the education. I think you'll hear from NAATPN a little bit later about Menthol Sunday, and I'll leave that to them to tell you more about stuff like that also raises this issue up within the context of the church or religious communities.
Terrific. Thank you, Reverend Brown, for your perspective. And yes, we have Shantae from NAATPN who's going to be able to speak more on No Menthol Sunday during our National Partner Resources wrap-up. So absolutely, we'll be getting to that. We have another question in the chat box specifically for Judy. Judy, you mentioned that you did a certification training so that pharmacists could bill Medicaid. Could you go into a little more detail on what that training entailed?
Sure, thank you. The best news of all is that, as any of you know, Frank Vitale and his good work, we literally brought him out of retirement. He keeps claiming he was retired, but he never is. An extraordinary individual who has worked with pharmacists for years and years and years. And so when we first identified, and it was actually through another program within our bureau that was working with the Pennsylvania Pharmacists Association, and they were actually looking to address insurers to be paid for some of the programs such as the diabetes prevention program. And they turned to us because they also were looking at the resource that a pharmacist could be, especially in our rural counties where access to care is sometimes very limited. And so we partnered with the Pennsylvania Pharmacists Association. We utilized Frank Vitale to develop 2 modules, specific modules for pharmacists. The first one being the background on tobacco, the health impacts, etc. And the second one being the pharmacotherapies that are in place and in using them. The Pennsylvania Pharmacists Association has added different modules that include motivational interviewing, and they have requirements for the pharmacists to complete all of the trainings before they get approved through our pre-approval process with DHS to be paid for their services by Medicaid. Pennsylvania's Medicaid services were expanded several years ago and have been underutilized, and believe it or not, they actually cover 70 15-minute units of counseling, and they cover all the pharmacotherapies, all the NRT, all forms of NRT, and all the pharmacotherapies as well. So we also recognize that this is a partner that will require boosters, and so Frank Vitale is also working to make sure that we follow this closely to make sure that adequate services are being provided. We would be happy to share what's happening with that. We are expanding it. Pennsylvania Pharmacists Association is in agreement to take on individual pharmacists who are not part of that association and allow them to go through their certified training. We're going to expand it through Frank with even more pharmacists. So it's something I think that states should probably really take a look at these partners that have been around for a long time, that you have them, you think of them in only one way, and as I mentioned before, the landscape is really changing. So we see this as a real opportunity.
Thank you so much, Judy. Our next question can go to Reverend Brown and Dr. Robinson. From an advocacy perspective, how can individuals or community members call on the government to put a stop to the companies that are marketing things towards our children?
So this is Dr. Robinson. I would say that from a government perspective, one of the things that I've learned since I've been here is, and this is specific to Pennsylvania, and it depends on kind of what the status, what states or what communities have in place. But we are a government of responsiveness, and so our governor takes it very seriously whenever a constituent writes a letter. So if there is a letter that comes in that references anything as it relates to health, that letter comes to our Pennsylvania Department of Health, and we have 30 days to respond to that letter, every single one that comes in. And so I think that having that accountability, and the governor keeps track of what comes in. So if there's one letter that comes in about someone who's concerned about hangnails, but 30 letters that come in about someone who's concerned about vaping, that elevates that issue. So the more people who kind of write into their governor or write into their elected official, I think as we get ready to think about special elections and midterm elections and those type of things, questions about that can also be directed to elected officials to see kind of what their positions are in terms of, does it make sense to regulate that? How do we change regulations? How can we make sure that young people's voices are heard? Sometimes young people like to speak at some of these debates that candidates have, and I think that also makes a stand and makes other people in the community aware of the issues, because the other issue is that if you don't have a young person in your household, you might not be aware of the marketing to younger people. And so I think having young people involved in that piece of it and advocating for themselves, but also speaking out, especially in terms of the time when it's an election, writing into elected officials and contacting kind of the highest governor or whoever the highest person is in your state, or even, I think at the federal and national level, we need to elevate this to that level as well. And I think really having the youth be empowered with the facts that they need to kind of deliver that message, but also, them demanding the right to live a healthy life and lifestyle.
Very excellent, Dr. Robinson. And we also want to make sure that we create an atmosphere that young people in particular, but that all people can participate in getting the message across. That's part of what we do is when we say we're going into organized communities, we're sharing information with them. We're finding out what they need. We're working. We're no longer strangers to each other. We learn what each other needs, and that way we can also find out what our mutual goals are. And that's what we try to tap into, that mutual goal. So if your goal is for a healthy community, a healthy lifestyle, fitness program, senior care program, we can tap into all of those agendas and say, okay, we've got a big one here that we all can deal with, and this is around tobacco addiction. And let's get into tobacco prevention and cessation programs. So we create the atmosphere so that can be done. And that's basically what we're doing right now. with the No Menthol campaign in Philadelphia. It's creating an opportunity for people to come on board in various ways. We also recognize that everybody doesn't want to be out front. Not everybody wants to be at a press conference, but some people will sit down and write a letter or send an email or create a petition. Some people will make a art piece that conveys our message in some way. I tap all and as many communities as I possibly can. And I raise the issue about the arts community because they can create murals and puppets and you name it to tell the story, to get the message out. We have to be creative like that in order to get the attention of the public and in order to pass on the information.
Excellent. Thank you both to Dr. Robinson and Dr. Brown for your insights there. We have a question for Dr. Robinson. Dr. Robinson, in your remarks, you mentioned how mental health and how tobacco use has impacted your family, and you mentioned how there was a lack of opportunities for smoking cessation along the continuum of care as your family member was treated for mental health disorder. So from your perspective in the state health department, how should public health departments reach out to other healthcare stakeholders and other community stakeholders to ensure that there are more smoking cessation opportunities for the populations that need that support the most?
That's an excellent question. So I think that it's important. So in Pennsylvania, our Department of Health and Department of Human Services are separate. And so I think from a government perspective, the first step for us in public health would be, or is, to sit down with our kind of sister agencies to figure out, okay, where does the most of smoking cessation counseling occur, and then connect with the partners who are providing that to say, hey, how do you feel you're doing on reaching this population, and do you feel like you have capacity to better reach it, and if not, what ideas do you have for reaching that population? So, I think we have a lot of information, a lot of materials, but we don't provide per se those services in those specific settings that are kind of regulated or overseen by our DHS colleagues. But I think connecting with those agencies that do it to say, hey, how do you think you're doing? And is there a way that we can help you partner to better reach these vulnerable populations? I think even within the vulnerable population, that is people who are afflicted with mental illness, there are further subsets of disparities there. So if we're talking about racial and ethnic minorities with mental illness, if we're talking about refugees, if we're talking about LGBTQIA populations, there's a history of marginalization even within the mental health and mental wellness community that we need to think of as well. And so in those cases, I think it's worth going to reputable allies and folks who do kind of general public health and for those specific marginalized populations to say, oh, I know that you work specifically with LGBTQIA populations in central Pennsylvania. What resources do you need to make sure that you're getting them good tobacco cessation resources? And so I think you can approach it from both sides of it, and I think that's a really important piece of it, is that making sure you're not just approaching it from the perspective of, okay, I'm the government, let me go to my government sister agency and make sure, oh, do you have the brochures and that's it. You also have to go to the community agencies and say, hey, are there things that we can get you that you need? And if it's not us, what are the challenges that you're facing, and how can we help you brainstorm to address the challenges you're facing to meet this unmet need?
Thank you so much, Dr. Robinson. This next question is for Judy. With regards to state strategy session, what partners have been most fruitful to work with for tobacco cessation and mental health outcomes?
What were the first couple words of the question again?
With regards to the state strategy session, which partners have...
That's a challenging one to answer because it was literally a cornucopia of the most extraordinary partners you can imagine. I think, again, we owe it to our national partners who guided us on exactly who should be at the table with us, and we struck gold. These were individuals who were literally the decision makers, and that was where we needed to be. And I think that the other part of it was there were many associations that represent some of the organizations, the facilities that serve behavioral health were also at the table with us. One example that has stayed in my mind was the two women from the state mental hospitals who came had already had their epiphany and recognized the benefits of having their facility go tobacco-free, not only for their patients but for the workers themselves. And in the beginning, we had different people at our table, and I happened to have an individual who represented an association that worked with the state mental hospitals. And it was very obvious early on that she was not in favor of this happening because her belief was, we take away so many things from our mental health patients, it just doesn't seem right to take away their cigarettes. And if you could have witnessed the epiphany she went through, I think it speaks volumes, just as Dr. Robinson has said. I think that the other part has been to recruit new members into our group. The other part of the session, in addition to the leadership, was the fact that there was some guided dialogue and that we all had to reach consensus to move forward to everything that we did. And it created an environment that gave everybody an opportunity to not only bring their skill sets, but to recognize and start realizing the linkages that we never think of. I don't know that that fully answers your question, but to me it was through the leadership we had with our national partners that we got the right people there. And I can't hold one group up from the other because we ended up singing in harmony. It was so amazing. I would like to comment on something Dr. Robinson said and go on to one of the other things that's so important for us is with these partners to dispel some of the myths and make sure we're very policy driven. So we're already talking to the MCOs and the organizations where they're in their network with drug and alcohol in their facilities. Many of the staff in those facilities are in recovery themselves, and their belief is that they don't feel that their patients want that they should address tobacco use. And we already know from our data that at least 70% of smokers think about quitting. And so Philadelphia, who has their own health department and is a metropolis, was one of our leaders in working with their inpatient mental hospitals. And they worked, it took them 2 years, but they have a policy in place that anyone admitted there is no tobacco, they're tobacco free, and they have to be provided with cessation. And so this has really helped us as we've moved forward. It's important to dispel the myths. It's important to use that word stigma. And it's really important to not just have us as talking heads, but to find the peer leaders, people who are just like them who can carry the message. I think that that's one of the most important things that all of us can do is to make sure that we don't just stay as talking heads, that we identify. And Dr. Robinson's example was wonderful about the kids, and Jesse also, using kids and getting them engaged early on. They are unencumbered, and they speak their minds and they speak their truth. And when you're working with legislators and the policymakers, they're a future voter. And so we do things like Advocacy Day and take our kids to talk about all these initiatives. You have to signal me somehow in the talkbacks to stop. I'm sorry.
No, you're fine, Judy. Thank you for your perspective and for commenting on those important topics. And that does bring us to the end of our Q&A time this afternoon. So thanks again to Judy and to Reverend Brown and to Dr. Robinson for your candid and so informative and inspiring Q&A portion of our agenda this afternoon. So now, before we conclude, we have the opportunity to hear about the tobacco control resources currently available from all of the co-hosting organizations joining us on this webinar. And so to start us off, I'm happy to share the floor with Tasleem Van Hatten of the National Behavioral Health Network. So Tasleem, if you'd like to walk us through your resources, please take it away.
Yeah, wonderful. Well, good afternoon, everyone. My name is Tasleem Van Hatten, and I'm a Director of Practice Improvement at the National Council for Behavioral Health. And I also direct the National Behavioral Health Network for Tobacco and Cancer Control, or NBHN. So I want to thank ASTHO for bringing us together today around these really critical topics, particularly during Mental Health Awareness Month. And I also want to thank Judy and Reverend Brown and Dr. Robinson, who spoke before me. All of their work is so important and inspiring. And I also had the great privilege and honor of being a part of Pennsylvania's November Summit that Judy mentioned, and it was really incredible to see the collaboration. And then I also want to thank in advance my sibling network, who will be speaking after me in a moment, and knowing that they carry forward this critical work every day, particularly around smoking and African Americans and health disparities. And so it's a great honor to present and work with them in this space daily. So I know that today we didn't touch on a lot of the statistics, but I did want to root us in a few statistics as to why today's call was so critical and why it matters even more around health disparities impacting individuals with mental illness and substance use disorders, as well as African Americans. And so approximately 1 in 4 U.S. adults have a mental illness or substance use disorder or both. Depending on the diagnosis, the rates of everyday cigarette use are incredibly high, sometimes almost double that of the general population. And then again, depending on the diagnosis, it's estimated that somewhere between 60 to 80% of individuals diagnosed with schizophrenia use tobacco on a daily basis. So I think that gives you an indication of how large and prevalent some of these issues are. In addition to that, although anyone can develop a mental health issue, African Americans sometimes experience even more severe forms of mental health conditions due to unmet needs and barriers. And I know my partners will talk a little bit more about that, but certainly barriers including lack of access to quality medical care, a desire from clinicians to focus on mental health rather than all aspects of health, a lack of consistent models of payment for tobacco cessation services, and then there's other insurmountable challenges, that I do believe are faced, such as that put African Americans at increased risk for developing a mental health condition, including homelessness, exposure to violence, and higher rates of incarceration. But I do think that due to the lack of access to quality mental health care, quality physical health care, and increased rates of poverty and homelessness, we see higher rates as well as acute and multi-generational trauma. So I really do think that it's important for us to ground our work in both tobacco and behavioral health and the health disparities that are manifesting. So I want to talk a little bit about NBHN. And so in order to address tobacco and cancer-related disparities among people with behavioral health conditions, the National Council does operate NBHN in partnership with the Smoking Cessation Leadership Center, Behavioral Health and Wellness, and the Michigan Public Health Institute. And we are one of 8 CDC-funded national networks, and we reach our members through training and technical assistance, as well as resource sharing and dissemination via bhtthechange.org, our listserv, and other social media resources. So currently we have over 1,600 members representing community health, mental health centers, state governments, public health agencies, hospitals, addiction treatment facilities, federally qualified health centers, so you name it. And our main activities continue to be resource development, so e-digests, resource lists, infographics, white papers. We engage in about 1 webinar per month on ongoing and emerging issues for behavioral health populations, so stay tuned for that, and you can visit bhtthechange.org to find out more about those monthly webinars. We also engage in state strategy sessions, which is what Judy talked to you about earlier, and which was part of the November meeting that happened in Pennsylvania, or that larger state strategy session that we were able to support along with our collaborative partners, helping states to develop those collaborative action plans to address the needs that are specific to their states. We also provide additional TA and funding for educational sessions in community behavioral health centers that are much more client-focused. And we engage in communities of practice, which I think also answers a question earlier that I believe Dr. Robinson answered. Our COPs support state tobacco control, cancer control, and health departments to collaborate meaningfully with community behavioral health organizations to improve system and organizational level changes around integrating tobacco cessation and cancer control programming. And then ongoing TA, because we know that a one-time training is not necessarily enough to move the needle, so ongoing training throughout. You can visit our website at www.bhthechange.org to certainly find more information as well as sign up for the network. So the few other very clear resources that I can help you with today, in addition to visiting bhthechange.org, signing up and having access to all those other ones I mentioned, is you can consider implementing a tobacco-free policy in your organization, regardless of what organization type you have, whether you're a state entity, whether you're a community behavioral health center, community center, public health agency. We can absolutely help you with this, regardless of what organizational type you are. In addition, I think that you can discuss with organizational leadership how you can implement or enhance your current tobacco cessation programming, and additional TA can be provided to you around that, whether that's regular tobacco screenings, tobacco cessation support groups, certainly increasing access to tobacco cessation medications, nicotine replacement therapies, developing out more robust partnerships with your state quit lines and alternative therapies. And then, once again, you can join our network, NBHN, to receive access to all of these resources I've mentioned and additional education that might help you. So thank you again so much. Please let us know how in the future we might be able to support you, your organization, and your state's needs moving forward, particularly around serving individuals with mental illness and substance use disorders.
Excellent. Thank you so much, Tesleem. And so next I will turn the floor over to Shantae Keith to walk us through the resources and upcoming opportunities from NAATPN Inc. So Shantae, please take it away.
Thank you so much, Josh. Good afternoon, everyone. I first want to say thank you to ASTHO and the National Council for Behavioral Health for coordinating this effort in a true partnership spirit. And I also wanted to thank our presenters, Judy and Reverend Brown and Dr. Robinson, for such wonderful information. And I'd also like to thank the participants for joining us on the call this afternoon. Again, my name is Shantae Keith, and I'm the Director of Programs for NAATPN Inc. NAATPN formally stands for the National African American Tobacco Prevention Network. And just like the National Council for Behavioral Health, we are one of 8 CDC-funded national networks that addresses tobacco use, cancer, and we also address HIV within the African American community. And so we do that in a whole host of ways. But mainly we provide training and technical assistance and support to state tobacco and cancer programs, to community-based organizations, to faith-based institutions, as well as higher learning institutions, more specifically HBCUs, historically black colleges and universities, on a myriad of issues, including how to educate and engage our community on policy issues and how to mobilize our community for policy change. And so having said that, our organization, one of our main focuses is menthol, and just like Reverend Brown so eloquently talked about earlier, we understand the disparate impact that mentholated tobacco products have on African Americans. And so we educate the community on the harms of tobacco use, predatory marketing, as well as menthol, and how it aids in youth initiation. One of the ways that we educate, particularly for faith-based communities, is through our annual event called No Menthol Sunday. During this event, churches across the country participate and do activities to educate their congregants, again, on the harms of tobacco use and how to quit smoking. Folks in the past have done things like their pastors have preached a sermon on that Sunday morning about healthy lifestyle choices and refraining from smoking tobacco products. They've talked about the dangers of menthol products and how to stop smoking from the pulpit. Some churches in the past have set up information tables in the vestibule or the lobby of the church to disseminate information about tobacco use and cessation. and others have put church announcements with facts about tobacco use in the program. And one year we even had a No Menthol Sunday parade. So the activities are very diverse and creative. And so one of the tools that we have to help others kind of think through some of the activities that they can do for No Menthol Sunday is our Community Action Toolkit. This document has resources and information such as menthol talking points. There are sermon topics that we have that represent several religions. So we have sermon topics for Muslims, Christians, Jewish, Hindu, and Buddhist. We also have some sample activities that folks can do on that day and examples of church announcements. One thing that has been really huge for us is our No Menthol Sunday church fans. We are completely sold out this year because they're such a big hit, but they have useful information on the fans, including tips for quitting tobacco use. So this is our 4th year coordinating No Menthol Sunday. This year we are celebrating on Sunday, May the 27th. Last year we reached about 36 states with our message, and this year we're going all out. We're trying to reach all 50 states this year. So in talking about No Menthol Sunday, the theme for this year is to find your freedom, which really encourages closet smokers in the church to be free of their nicotine addiction and use the appropriate resources to assist with quitting. And so the resource that we are featuring for our Community Action Toolkit is Pathways to Freedom DVD. This is a free resource that is designed to really assist individuals and community leaders in their efforts to become smoke-free. It's a documentary-style video that is a smoking cessation program specifically targeting African Americans. And so folks can go to our website, which is www.naapn.org, to request a copy of the DVD. And so one of the things that I'm really excited about and has been a labor of love for our NAATPN staff is that we are working on and coordinating the first ever State of Black Health National Conference. And this conference will be from September the 11th through the 13th in Atlanta, Georgia. We are going to convene a diverse group of people that are interested in improving the health outcomes of the African American community. And what we really want is for folks to walk away with actionable steps and strategies that they can implement in their communities so that we can really move the needle on some of the most pressing issues that impact African Americans. So we'll be talking from 3 different standpoints. We're focusing on chronic disease and wellness, economic issues, and the last is institutional injustices. And so what that will look like is topics such as, for chronic disease and wellness, we'll be talking about cancer, HIV, tobacco use, mental health, diabetes, and heart disease. For economic issues, we'll be talking about livable wages, wellness programs, and discrimination in the workplace. We'll even be talking about how mental health and tobacco use can affect employability. Last, we will be discussing institutional injustices such as human trafficking, racism and its impact on health, housing and transportation, as well as food security and food deserts. And so registration is open and we are accepting abstracts. To register, please visit thestateofblackhealth.com. And so just to briefly mention, we do have some resources on our website, such as handouts. If you look on our site, we have fact sheets about menthol, cigarillos, and cigars. Dr. Robinson briefly mentioned a new product that young people are using called Juul. We have a fact sheet on our website about that vaping device as well. And so please visit our website if you ever have an event or just need some information about menthol. And so to find us on social media, NAATPN social media profiles are under Black Body Health. We wanted to name our social media platform Black Body Health because we were looking for a name that was consumer friendly. And so NAATPN, of course, has moved we address tobacco use, but we also address so many other issues that we wanted a name that really talked about total body health for African Americans, including mind, body, and spirit. So we found that the name Black Body Health resonates with community folks that we are trying to reach. So you can find us on Facebook, Twitter, and Instagram at our Black Body Health handle. And so on social media, you will find information on a plethora of issues. We try to stay current and post the latest information on data, research, public health campaigns. And we try to stay as relevant to the times as we can and really post things that resonate with the community. For example, one of my favorite articles as of late is that our communications director wrote an article entitled 4 Health Messages You Missed During Your Visit to Wakanda, which was written right after the movie Black Panther premiered, and you can all find that article on our website as well. And so I'll stop right there and just say thank you again for allowing me to share some of the resources that NAATPN has. If you'd like more information about any of the discussion items I just went through, please visit us again at naaptin.org, and I'm sure that our contact information is on a following slide. But thank you so very much. And if you all need anything from NAATPN, please don't hesitate to reach out to us.
Terrific. Thank you so much, Shantae, for those updates from NAATPN. So I'll take a quick opportunity to discuss the latest tobacco resources on the ASTHO tobacco webpage before wrapping us up, and a link to that webpage is available on screen. So ASTHO maintains a statepublichealth.org blog, which features brief summaries on a wide variety of emerging public health topics of importance to state public health departments and their partners. Several tobacco-related blog posts featuring commentary from ASTHO staff and external experts have been published to the blog in recent months, and in particular, I want to highlight the blog post ASTHO published on menthol tobacco use and its disproportionate impact on African American communities across the United States. And this blog post featured insights from Shantae's colleague, Del Monte Jefferson, the executive director of NAATPN Inc. And all the recent blog posts are available in the written resources and materials archive on ASTHO's tobacco webpage through the URL you see there on screen. ASTHO also maintains an archive of virtual event recordings and podcasts, and we have 3 new resources that have been made available there over the past month. Most recently, we've added the recording of the 45-minute virtual coffee chat that ASTHO convened to discuss how state health departments can address e-cigarette use in schools. ASTHO President-elect Dr. Nicole Alexander-Scott, the state health official of Rhode Island, was generous enough to join us there and provide her insights as part of that coffee chat. We also have a recording available from our Ask the Experts virtual session, in which diverse stakeholders provided insights on the intersection between tobacco use and opioid use, and that event was moderated by current ASTHO President John Weisman, the state health official of Washington State. And then finally, we have a podcast recording available that explores how state health departments can support the forthcoming HUD rule and encourage the implementation of smoke-free public housing policies. Materials from this webinar will also be made available on that archive page. And finally, given the topic area of our discussion this afternoon, I wanted to make sure to mention ASTHO's interactive infographic that explores how state health departments can address tobacco-related disparities and promote health equity. ASTHO launched this resource collaboratively with the 8 CDC-funded national networks that work with populations experiencing disproportionate death and disease burdens resulting from tobacco use, and that includes NAATPN Inc. and the National Behavioral Health Network. And so ASTHO invites everybody to view this interactive infographic via the ASTHO website or through the direct hyperlink below to gain an improved understanding of tobacco-related disparities. So as we wrap up here, I want to let everyone know that you will be directed to a survey at the conclusion of the webinar, and a link to the survey will also be made available to attendees via email. We ask that you take a couple minutes to complete the survey, as it provides ASTHO and the colleagues joining us today with invaluable input on how we can improve future webinars and future virtual learning opportunities. And so that concludes today's webinar. So I would like to once again thank all of the speakers and partners who joined us this afternoon to make this collaborative webinar possible. I'd also like to thank my ASTHO colleagues for helping me moderate today's webinar. A recording of this webinar, again, will be sent to you via email later this week and will also be available on the ASTHO website. And any additional questions you have about the work of ASTHO, NAATPN, or the National Behavioral Health Network can be directed to the folks you see on screen. So thank you again so much for joining us this afternoon, and please enjoy the rest of your day.
Thanks, everyone.